Namaste, हमेशा खुश रहो। Today I am discussing a session that is important when we are taking radiographic images of different regions. So it is a session particularly important when imaging of the course name is radiographic techniques of full body in BScRT second semester. Okay. I am Gaurav from the Faculty of Cervical Diagnostics and in the Department of Diagnostic Community Health, JV'N University, Jaipur. Namaste. In today's session, we will discuss about the cervical spine AP and lateral view of X-ray technique, procedure or indications. Okay. So the cervical spine AP view. AP cervical spine projection is a part of the cervical spine series or cervical spine views. Indications: this projection helps to visualize pathology relating to C3 to C7 in the anatomical position, demonstrating any compression fracture, clavicular fracture, and herniated nucleus pulposus. Okay, these type of fracture or herniated nucleus pulposus disease. The patient position. Patient position erect, positioned erect in the patient positioned erect in AP position unless trauma, when the patient will be fine. Okay. In conditions such as trauma, the patient position or patient asks patient to lie supine on the table. Patient's shoulders should be at equal distance from the image receptor to avoid rotation. Okay. Chin should be raised to align the lower margin of the upper incisor to the masseter tip base of the skull. The technical factor or exposure factors. Central point is central ray. The central ray is a midline centered at the level of C4 to enter immediately below the hyoid bone. Okay, and the 50 degrees cephalic angle or cephalic angle tube is angled at a 15 degree cephalic. Collimations laterally to include the entire cervical spine, superiorly to include C2 and inferiorly to include T2 for second vertebrae or cervical second vertebrae. Orientation. The orientation should be portrait. Detector size is 8 by 10 inches or 18 by 24 centimeters. Exposure factors that is used in cervical spine AP view is between the 60 to 70 kV and MES is in the range of the 12 to 20 MES. Okay, the SID, source to image receptor distance, should use 100 centimeters grid. Yes, grid is used because the exposure factor is larger or higher than other less factors used. Image technical evaluation: cervical spine intervertebral disc spaces should be open. Spinous process should be midline, equidistant to the pedicles, indicating that there is no rotation. Okay. The next point is practical point. And this point, make sure that any removable artifacts such as earring, glasses, or metal dentures are removed to avoid obscuring the anatomy of interest. Next view is cervical spine lateral view. Is the lateral projection cervical spine. As technology advances, CT has replaced this projection, but in many institutions where the CT is not available, then cervical spine lateral view is taken. Indications of projection has to utilize pathology involving the entire cervical spine, orthogonal to the AP view, and is often performed in the trauma setting. It also helps to demonstrate any adjacent soft tissue structure, osteoarthritis, spondylosis. Patient position. The patient is supine or erect depending on trauma or follow-up. The detector is placed portrait running parallel to the long axis of the cervical spine, means parallel long axis of the cervical spine of the patient left side, on the patient left side. Inform the patient that the image will be taken on suspended expiration. Okay, ask the patient to hold the breath and expire the breath. After that, no breath is taken by the patient. Okay. Technical factors or exposure factors. The central point of central ray should pass from 2.5 cm above the jugular nose at the level of C4. Collimation superior to C1, inferior to T1, anterior to include soft tissues, superior to C1, inferior to T1, anterior to include soft tissue, posterior to include soft tissue. Orientation should be portrait means style. Landscape means style. Portrait means style. Okay. Portrait should be portrait or detector size. 8 by 10 by 12 inches. Exposure factors 60 to 70 kP, and MAS is in the range of 16 to 30 MAS. As ID 150 to 180 centimeter or okay, grid is used in this view. Image technical evaluation, there should be a clear visualization of T1 to T1. The vertebral bodies are superimposed laterally. The articular pillars and the zygophysial joint are superimposed. Okay. So the traction, practical traction, this projection may require inferior traction of the arms to better visualization. T1. This should only be performed by a qualified professional. If T1 cannot be visualized, a swimmer's lateral view projection may be required. Okay. Thank you. Namaste. In today's session, we will discuss about the lumbar, AP, and lateral view. Lumbar spine, anterior posterior image is the lumbar spine in the anatomical position. The lumbar spine generally consists of 5 vertebrae. Lumbosacral transition vertebrae. Indications for taking the lumbar spine AP view images. Indications. This projection is utilized in many imaging contexts, including trauma, post-operatively, and for chronic conditions. Chronic condition, spinal imaging should be taken erect in non-trauma conditions. To give a functional overview of the lumbar spine, otherwise patient with a suspected spinal injury must remain in the supine position without any movement. Patient position. The patient is erect or supine depending on clinical history. In the supine projection, hands are placed by the patient side. Okay. If performing erect position the patient in the PJ. This has numerous advantages, including to the reduced dose to the gonadal region and utilization of beam diversion. Arms can be placed by the side or the handlebar of the erect bucket can be held for the patient's stability. The weight bearing PA view can be called the Ferguson technique. Okay, this is the AP erect or PA. Technical factor or exposure factor. In addition, use suspended expiration of patient is required. Center point the level of the iliac crest at the mid sagittal plane. The central ray is perpendicular to the image. Means it is image receptor. The central ray is perpendicular to the image receptor. Collimation superiorly to include the T12 L1 junction, inferiorly to include the sacrum region, lateral to include the transverse processes and sacroiliac joint, SI joint. Orientation should be portrait and the detector size that is used is 14 by 17 inches or 35 by 43 centimeter. Exposure factors for the lumbar AP view is 65 to 75 kVp or MAS is in the range of 30 to 50 MAS. SID 100 centimeter grid. Yes, grid is used because high exposure radiation is delivered in this view. Image technical evaluation, the entire lumbar spine should be visible with demonstration of T11, T12 superiorly and a sacrum inferiorly. No patient rotation as evidenced by the central spinal processes and the symmetrical appearance of the sacroiliac joint or iliac wings. Intervertebral joint are visualized. Adequate image penetration and image contrast is evident by clear visualization of lumbar vertebral bodies, particles and facet joints and both clavicular and cortical bone demonstration. So we can visualize these parts of the vertebral column or vertebrae body, pedicles, facet or trabecular or cortical bone. Okay. So the practically the three columns. The concept of a thoracic lumbar spinal fracture is of particular importance when assessing the image of the pathology. Take particular care when imaging patient on a trauma trolley. Then the image receptor is aligned to the central ray to prevent anatomy exclusion or grid cutoff. Okay, so this is the lumbar spine AP view. Next view is the lumbar spine lateral view, which is the lumbar spine which generally consists of 5 vertebrae. Lumbar 5 vertebrae. Indications. This projection shows an orthogonal view of AP and it is utilized in many imaging contexts, including trauma, post-operatively, chronic conditions. This view is also ideal in characterizing spinal alignment. The spinal imaging should be taken erect in the non-trauma setting, non-trauma conditions or non-trauma position to give a functional overview of the lumbar spine. Otherwise, patient with a suspected spinal injury must remain in the supine position without any patient position. The patient is positioned erect, supine or lateral recumbent depending on the clinical history. In the lateral equidistant position, the position of the patient so that the humeri are extended 90 degrees to the thorax with the elbow flexed so that the forearm are parallel to the thorax. Spinal curvature in the AP projection will determine if a right lateral or left lateral is performed. When implementing horizontal beam techniques, ensure the distal upper limb are not overlying the region of interest. The technical or exposure factor expiration to minimize superimposition of the diaphragm over the upper lumbar region or spine. Centering point, the level of the iliac crest. The coronal centering point is directly over the lumbar vertebrae, which corresponds to the posterior third of the abdomen. The central ray is perpendicular to the immediate abdomen. Next is the collimation. Superiorly to include the T12, L1, inferiorly to include the sacrum, anterior to include the anterior border of the lumbar vertebral body, posterior to include all elements of the posterior columns, particularly the spinous process. Orientation should be portrait. It exercise is in the range of 14 to 17 inches. Exposure factor that is used is in the range of 70 to 80 kVp and MAS 40 to 60. As ID 100 centimeter is used. Grid, yes, grid is used because of using high exposure factor. Image technical evaluation or radiographic appearance, the entire lumbar spine should be visible from T12 L1 to L5 S1. Imposition of the greater sciatic notches, the superior articulating facet and the superior and inferior end of plate and plate. This indicates that true lateral has been achieved. Okay. So this is the view of lumbar spine lateral. So I think these views or this knowledge is very much useful for you, or you can get a good knowledge or good practical exposure after listening or correlating with practical exposure in hospital. Okay. Thank you. Thank you. The session is over. I think you are satisfied with the session. If you have any query, then put it into the comment box. I will resolve it later. Thank you. This session is powered by digital version 2.0, created by Women's University, Jaipur. The session is over.